Yeah, nice.
So today's topic is breast. Breast is a very important topic. Everybody must know what is breast. Surgically, it is very important. Breast is a skin appendage which develops from modified sweat gland deep to nipple. Adult breast lies prominently on deep of pectoral major. So it's present on the pectoral major. It extends from second to sixth costal cartilage on the chest wall. Medially, it extends almost to midline, and laterally it continues as an axillary tail of breast. Over the lateral edge of pectoralis major into the axilla. Superficially is separate from skin by subcutaneous fat, except for areola and nipple. The breast substance consists of glandular tissue and surrounding fat. Blood supply of the breast mainly from the branches of internal thoracic, that is mammary artery, and intercostal arteries, which pierce the intercostal muscles, and laterally from the branches of lateral thoracic artery. Lymphatic drainage is very important, mainly to axillary lymph node, but also to internal thoracic node, that is also called internal mammary node from the medial breast. We mainly do axillary dissection for the lymph node. Basically, breast is a systemic disease which is spread by the locally spread by the lymphatic spread. So lymphatic spread it is to the mainly to the axillary group of lymph node. So we must know lymphatic drainage of the breast. It also is spread by the blood to the lung, liver, and to brain, and mainly to bone. The axillary contents are the fat and lymph nodes, boundaries by the axillary wall, bounded by the axillary wall, axilla. Medial wall is bounded by chest wall, covered by serratus anterior. Anteriorly, anterior wall is formed by pectoral muscle and clavipectoral fascia. Posterior wall comprise latissimus dorsi, teres major, and subscapularis muscle. The axillary vessels and brachial plexus lie along the narrow superior wall of the axilla. Axilla is very important in the breast. Axillary lymph node are arbitrarily divided into level 1, 2, and 3, depending on the relation to the pectoralis minor muscle. Level 1, lateral and below the muscle is called level 1. Level 2, behind pectoralis minor muscle, and level 3 above and medial to the pectoralis minor muscle. So the level of axillary lymph node is also important. We have to do in my MRM, we have to do axillary dissection at the level of third, up to the level of third. Now come on the investigations of breast symptoms. Although accurate history and clinical examination are important method of detecting breast disease, the number of investigations that can assist in diagnosis are as follows. Basically, we have to do clinical examination. So clinical examination is very important in the breast disease. Only some investigations will assist in the diagnosis. Examination proceeds inspection, palpation, require careful observation of the patient with arm at rest and also elevated arm to lift the breast, and also observe on bending forward to the patient. So come on the first investigation is the mammography. Finding size and localization of mass lesion, microcalcification signify malignancy in the mammography. Soft tissue shadow is irregular and speculation are present in the mammography. Second important investigations is the ultrasonography. Finding size and localization of mass lesion. Ultrasound is useful particularly in young women with dense breast whom mammography is difficult to interpret or distinguish cyst from solid lesion. So to distinguish cystic from solid lesion, ultrasound is important. It can also be used to localize impalpable area of breast pathology, also used for axilla and also to guide percutaneous biopsy of suspected gland. So USG guided FNSC can be done. Next important investigation is the FNSC. It is very useful for carcinoma breast. USG guided FNSC also can be done. It is done with 23 gauge needle using FNSC aspiration special syringe. It is least invasive but fast negative do occur mainly through sample error, and invasive cancer cannot be distinguished from the situ disease. So in carcinoma in situ, it cannot be differentiated with the FNSC by the invasive disease. Two-cut or four-cut biopsy, it is also very important. It is done under local anesthesia. It gives histological evidence and differentiate between ductal carcinoma in situ and invasive disease, and also allow the tumor to be stained for receptor status. So receptor status and tissue diagnosis can be done by the two-cut. This is important before commencing neoadjuvant chemotherapy. MRI, it was one of the important investigations for increasing breast interest. In number of settings, it can be useful to distinguish a scar from recurrent in women who have had previous breast conservative surgery for cancer, although it is not accurate within 9 months of radiotherapy because of enhancement. It is best modality for the breast of women with implant. It is less useful than USG in management of axilla, both in primary cancer and recurrent disease. But it is important in distinguish scar from recurrence in women who have had previous breast conservative surgery. Although biopsy can be performed with MRI guided, this is complicated because of configuration of imaging system. So MRI guided FNSC can be done or biopsy can be taken. With improved USG equipment, and MRI detectable lesion can often be found on second look USG using USG and biopsy using this modality. So it is also important. Now come on the triple assessment. It is very important. Everybody must know triple assessment. Triple assessment is the combined evidence of clinical mammography and tissue sampling taken either cytological or histological analysis as a result in confident pre-operative diagnosis in almost all the patients. This lesion is palpable. Surgeon can be taken core biopsy with a specialized design needle through small stab incision in the overlying skin, which has been infiltrated with local anesthesia. Core biopsy of impalpable lesion detected on imaging requires sophisticated histostatic localized device or guided by USG. A pre-operative definitive diagnosis can usually be made out, but excision biopsy may have to be the final diagnostic procedure. Now come on the benign breast disease. That is fibroadenoma. Everybody knows there are many patients come young, especially young female of 15 to 25 years of age group. It is benign. Encapsulated tumor occur commonly in young female. Presently, it is conserved as a hyperplasia of single lobule of the breast. It is most common benign tumor of the breast. It is abbreviation of normal development of lobule. It is usually grown up 2 to 3 centimeter in size. A fibroadenoma doesn't require excision unless associated with suspicious cytology. RB, it is very large. A patient expressively desired the lump to be removed. Clinical features of fibroadenoma is the painless lump in one of the quadrant. It is smooth, firm, non-tender, well localized, freely movable with the breast tissue. That's why it's called mouse in the breast. Axillary lymph node is not enlarged in the fibroadenoma. Investigations are the mammography, well localized, smooth, regular shadow, FNSC, and USG to confirm solid nature. Treatment is the excision through circumammary or submammary excision. Second, we can say benign tumor is the phyllodes. This is the benign tumor occurring in young human age of 40 years, but can occur in young woman as well. Clinical features: large, sometimes massive tumor with an eventually bosselated surface. Occasionally, ulceration of forelying skin occur because of pressure necrosis. Despite their size, they remain mobile on the chest wall. Nipple retraction are not present. Swelling is smooth, non-tender, soft, fluctuant with necrosis. Skin over breast is stretched, red and dilated vein over it. Tumor is warmer, not fixed to skin or deeper muscle in the chest wall. Lymph node are not usually involved. Recurrence is common. Histologically, wide variation of their appearance with some of low malignant potential resembling fibroadenoma, other having high mortality index, which are histologically worrying. Investigations by USG, FNSC, mammography, chest X-ray in malignancy to see secondary in the lung. Treatment is the wide local excision or mastectomy. Massive tumor required tumor and those of malignant type require mastectomy. So, wide local excision as well as mastectomy. Third, benign disease is the traumatic fat necrosis. It is due to either direct or indirect trauma. Clinical features: smooth, hard, non-tender, and adherent to breast tissue. It is non-progressive and non-regressive. Investigations: FNC show chalk fluid with fat globule. Mammography, differential diagnosis is the carcinoma breast. Treatment is the excision. Next is the galactosile. It is lactating woman, seen in lactating woman. It is due to blockage of lactiferous duct resulting in enormous dilatation of lactiferous sinus. It is retention cyst in subareolar region attending large size. Clinical features are lump in lower quadrant, unilateral, large, soft, fluctuant with a smooth surface, non-tender. It may get precipitated or get calcified. When it is calcified, it may make carcinoma. It is intended for an abscess. Investigations: ultrasonography. Treatment is excision by submammary incision. When abscess is formed, INT can be done. Next is the mastitis. We have seen many patients of mastitis. It can be subareolar, inframammary, or retromammary. Subareolar mastitis, it is the infection under the areola due to crack in the nipple or areola. It results from infected gland of Montgomery or furuncle of areola. Often it is associated with Duct ectasia causing formation of abscess and fistula. Clinical features: red, inflamed, edematous areola with tender swelling underneath. Differential diagnosis: the Pegas disease of the nipple. Treatment: IND under local anesthesia. Intramammary mastitis. Lactational abscess of the breast, commonly seen in lactating women. It is very important. We have seen many patients of lactating women who comes with the intramammary mastitis. Preceding factor are the cracking nipples, retracted nipple, improper cleaning of nipple, inadequate milk sucked by baby or milk expression causing stasis, infection from the mouth of baby, hematoma get infected. Mode of infection: bacteria enters the breast during sucking through the cracked nipple. Occasionally, it can be from hepatogenous spread. Bacteria are the Streptococcus aureus causing clotting of milk in the blocked duct and multiply there. Duct initially blocked by epithelial debris or by retracted nipple. Initially, it began in one quadrant but later involved entire breast. Clinical features of continuous throbbing pain in the breast, fever, diffuse redness, tenderness, and browning induration in the breast, purulent discharge from the nipple. Entire breast may get involved even eventually. It is difficult to differentiate differential stage of mastitis, stage of cellulitis from stage of breast abscess formation. When it is treated by antibiotic without IND, it may get organized to form non-tender hard breast lump with a sterile pus inside the stage of antibiotic formation. Differential diagnosis: inflammatory carcinoma of the breast. Treatment: antibiotics and repeated USG guided aspiration done under general anesthesia. Counter investigations may be needed. Indication of drainage in mastitis. Mastitis, it is not resolving with antibiotic. If it is not resolving with antibiotic in 48 hours, persistent fever and progression of mastitis, brown induration. Do not wait for abscess to form or fluctuation to develop, and it should be done. Complications of mastitis: antibiotic formation, sinus formation, necrosis, fistula formation, recurrent infection, bacteremia, septicemia. Suppression of lactation is often required by giving bromocriptine 2.5 mg BD for 2 weeks. Non-lactational abscess of breast, it is commonly occur in duct ectasia and perioral infection. Common organism are bacteria, Streptococcus anaerobes. It is commonly recurrent with tender swelling areola. Treatment is antibiotic, repeated aspiration, drainage, and cone excision of duct is required. Next is tuberculosis of breast. It is rare, usually associated with pulmonary tuberculosis, present with swelling in breast, with cold abscess, sinus, and typical bluish appearance of surrounding skin with matted lymph node in ipsilateral axilla. Differential diagnosis of tuberculosis of breast is the carcinoma breast. Investigations of FNAC. Frozen section is usually to differentiate from carcinoma in excision biopsy. Treatment: antibiotic, INH, rifampicin, ethambutol, and pyazidamide. Cold drug therapy for 6 months. Drainage of cold abscess. Mastectomy is not done. Now come on the retromammary mastitis. It is due to tuberculosis of intercostal lymph node or rib beneath or suppression of intercostal lymph node. Breast is normal. Cause of tuberculosis of intercostal lymph node, tuberculosis of rib beneath, suppression of intercostal lymph node, empyema necessities, infected hematoma. Investigations is the chest X-ray to rule out pulmonary tuberculosis, FNAC to rule out carcinoma, ESR, peripheral smear, USG of breast and chest wall. Upper CT chest may be needed. Treatment cause has to be treated and through submammary or retromammary incision. Ductal papilloma is the next benign disease. It is commonest cause of blood discharge from the nipple. It is usually single lactiferous duct. It blocks the duct, causing ductal dilatation. Clinical features: papillopleural swelling, projection usually seen near the nipple orifice. Blood stain discharge, nipple is common, but serous discharge can also occur. Single papilloma is not pre-malignant, but multiple papilloma is many that can be pre-malignant condition. Investigation: study of discharge, ductogram, treatment microdectomy, probed electriferous duct is open and the papilloma is excised using tennis racket incision. हो गया, ये तो कंप्लीट हो गया। इसको बंद करके वो अलग कार्सिनोमा ब्रेस्ट खत्म। इसी के साथ हो जाएगा, अलग होगा? इसी में ही करवा दो। हाँ, इसी में कर, इसके साथ में करते हैं। तो ये तो मतलब 20 मिनट से ज़्यादा का नहीं होगा। कार्सिनोमा ब्रेस्ट और मैस्टेक्टोमी ये वाला ना सर्जिकल ट्रीटमेंट। Now come on the carcinoma breast, very important. Previously we talked about the surgical anatomy of the breast and benign breast disease. Today's topic is the carcinoma of the breast. It is very important. Breast carcinoma is the most common cause of death in Western countries and women of the Western countries. 1 in 12 women will develop the disease during their lifetime. Etiological factor for the breast carcinoma is the geographical carcinoma breast common in Western countries. Age: carcinoma breast extremely rare below the age of 20, but thereafter the incidence steadily rise so that by the age of 90 years, 20% of men are affected by the carcinoma. Gender: less than 0.5% patients with breast cancer are male, rarely female are involved. Genetics: it occurs more commonly in women with family history of breast cancer than in general population. The first degree relative. Diet: low in phytoestrogens increase risk. High intake of alcohol is associated with increased risk of developing breast carcinoma. Endocrine: breast cancer is more common in nulliparous women. Breastfeeding appear to be protective. First child at early age is also protective. Early menarche and late menopause having high risk of malignancy. Obesity increased risk of carcinoma breast. Oral contraceptive pills and hormone replacement therapy increase the risk. Previous radiation: majority of women exposed to atomic bomb at Hiroshima and Nagasaki increase incidence of carcinoma breast. Patient who has taken radiotherapy in past for Hodgkin's lymphoma increased risk of carcinoma breast. Breast cancer in contralateral breast common, BRCA1 and BRCA2 gene mutation. Gynecomastia in male breast is responsible for the development of carcinoma breast. Pathology of breast carcinoma: it occurs from the lactiferous duct cell as a ductal carcinoma. Breast carcinoma occur from lobule is called lobular carcinoma. It may be in situ carcinoma, is pre-invasive carcinoma which has not reached the epithelial basement membrane. It may be ductal carcinoma in situ or lobular carcinoma in tissue. Invasive carcinoma can occur eventually. describe terms they are used to classify breast disease as serous, meaning wooden, or medullary means like brain. So pathologically, breast cancer can be serous or medullary. Current nomenclature is ductal carcinoma, most commonly variety with lobar carcinoma. This is the result of blockage of subdermal lymphatic with carcinoma cell. Inflammatory cancers usually involve at least 1/3 of the breast and may mimic breast abscess. A biopsy will confirm the diagnosis. Show differentiation carcinoma cells. It is usually used to be rapidly fatal. But aggressive chemotherapy and radiotherapy and salvage, the prognosis has improved considerably. In situ carcinoma, it is pre-invasive cancer that has not reached the epithelium basement membrane. This was previously rare, usually asymptomatic. Finding in the breast biopsy specimen, it is becoming increasingly common because advancement of mammographic screening. It is now 20% of cancer detected in UK. It is carcinoma may be ductal or lobular. Lobular ductal carcinoma in situ or lobular carcinoma in later, often being multifocal or bilateral. Both are markers of later development of invasive cancer, which develop 20%. Although mastectomy is curative, this constitutes our treatment in many cases. The best treatment for carcinoma situ is the subject of number of ongoing clinical trials. Ductal carcinoma situ may be classified using one number of system, which combine the patient's age, type of DCIS, presence of microcalcification, extent of resection margins, size of disease. Patient with high score benefit from radiotherapy upon excision. Whereas those low grade who tumor is completely excised, no further treatment is required. Staining for estrogen and progesterone receptor is now routine, as their presence will indicate use of adjuvant hormonal therapy with tamoxifen or never aromatase inhibitor. Tumor are also stained for growth factor receptor. A patient who are positive can be treated with monoclonal antibody, that is trastuzumab, either in adjuvant or leptin setting. Now come on the Paget's disease of breast. Paget's disease of nipple is superficial manifestation of an underlying breast carcinoma. It is present as eczema. It can be confused with eczema. Condition of nipple and areola which persists despite local treatment left the underlying carcinoma will sooner or later become clinically evident. Nipple eczema should be biopsied if there is a doubt about its cause. Microscopically, Paget's disease is characterized by presence of large white cells with abundant clear pale staining cytoplasm in Malpighian layer of epidermis. Now come on the spread of cancer. How it is spread? It is very important. It can be spread by, it is the systemic disease. It is spread by local lymphatic and blood. Local spread, the tumor increase in size and invade the other portion of the breast. It tend to involve the skin and to penetrate the pectoral muscle and chest wall if diagnosed later. Lymphatic spread, lymphatic metastasis occur primarily to axillary in internal memory lymph node, mainly to the axillary lymph node. The involvement of lymph node has both biological and chronological significance. It represents not only an evolution even in a spread of carcinoma, but is also a marker of metastatic potential of tumor. Involvement of supraclavicular and contralateral lymph node represent advanced disease. Spread by bloodstream, it is spread skeletal to the skeletal muscles, occurs, although the initial spread may be via the lymphatic spread system. In order of frequency, the lumbar vertebra, femur, thoracic, rib, and skull. These deposits are generally osteolytic. Metastasis may also commonly occur in lung, liver, brain, and occasionally to adrenals and also ovaries. So, breast carcinoma can be spread to the lung, liver, spleen, and mainly to the bone. Clinical features very important. Although any portion of breast, including axilla, may be involved, cancer is found most frequently in upper and outer quadrant of the breast. Most breast cancer will present as a hard lump, painless hard lump, which may be associated with involving of pimple, involving of nipple. As the disease advanced locally, there may be skin involvement with PUD orange. This is described as a cancer in cruise when the disease progress around chest wall. About 5% of breast cancer will be present with either locally advanced disease or symptoms of metastasis disease. Thus, this figure is much higher in developing countries. Patient must undergo staging evaluation and the full of the disease can be ascertained. This will include a careful clinical examination, chest X-ray, X-ray of the CT chest, abdomen, CT abdomen, and also bone scan. This is important for both prognosis and treatment. A patient with widespread visceral metastasis may obtain an increased length and quality of survival from systemic hormone therapy or chemotherapy, but is unlikely to benefit from surgeries as well. Will die from her metastasis before local disease become problem. So we must see important to see spread to the lung, liver, bone, and the chest. In contrast, patient with relatively small tumor less than 5 centimeter in diameter, confined to breast and ipsilateral lymph node, rare staging beyond good clinical examination as a pickup rate for distant metastasis is so low. Currently, a chest radiograph, full blood count, liver function test all recommended for screening of the patient with early breast cancer. So we must do chest radiograph, blood count, LFT for the breast carcinoma. Summary of the presentation of carcinoma of the breast. It is very important. Lump in the breast, which is hard, painless. Nipple discharge is the commonest common presentation. Ulceration and fungation. Axillary lymph node enlargement. Supraclavicular lymph node enlargement. Chest pain and hemostasis. Bone pain and tenderness and pathological fracture. We see many patients of the fracture who has breast carcinoma. Many patients may have a hemoptysis and chest pain who have carcinoma breast. Pleural effusion is also a commonest presentation. Ascites, liver secondaries, ovarian tumor, pain in the lump in 10% cases when nerve is involved. Now come on the staging of carcinoma breast, Manchester and TNM staging. Manchester staging, stage 1, tumor in the breast not involve pectoral or deeper plane. Skin involvement, if present, is lesser than the size of tumor. Lymph node is not palpable in stage 1. Stage 2, same as stage 1, plus mobile discrete lymph node palpable in ipsilateral axilla. Stage 3, tumor fixed to pectoral muscle or skin involvement more than tumor size or ipsilateral axillary lymph node adherent to each other are fixed. Stage 4, tumor fixed to chest wall or cancer in cruise. Skin involvement wider than the breast involvement. Ipsilateral or contralateral supraclavicular lymph node or opposite breast or opposite axillary lymph node spread. and spread to bone, lung, liver, or inflammatory carcinoma of the breast. TNM staging, it is very important, can be asked in the examination. T1, tumor size less than 2 centimeter in greatest diameter. T1A, 0.1 to 0.5 centimeter. T1B, 0.5 to 1 centimeter. T1C, 1 to 2 centimeter. T2, size 2 to 5 centimeter. T3, size more than 5 centimeter. T4, tumor fixed to chest wall or skin. T4A, fixed to chest wall. T4B, fixed to skin. T4C, T4A plus B. T4D, inflammatory carcinoma breast. Note, N0, no lymph node. N1, axillary lymph node, mobile ipsilateral. N2, axillary lymph node fixed to one another, and other structure are only internal memory lymph node involved, not axillary lymph node. N3, supraclavicular lymph node, edema of arm, internal memory lymph node, ipsilateral and internal memory plus axillary lymph node. Metastasis M0, no metastasis. M1, distal metastasis. Investigations in the carcinoma breast, it is very important. We have already told mammography, size and location of mass, microcalcification signify malignancy, soft tissue shadow, irregular speculation, USG to find out whether lesion is solid or cystic. FNC is very useful in diagnosis carcinoma breast. USG guided FNC is also used, but negative result is difficult to interpret because it may, due to sampling error, also require further diagnostic method. FNC of opposite breast, opposite lymph node, opposite axillary node are also often required. Through-cut biopsy, it gives clear histological evidence and also confirm DCIS. FNC cannot confirm DCIS. These allow proper neoadjuvant primary chemotherapy and also give receptor status of tumor. Excision biopsy is done only when FNC is inconclusive and facility of frozen section is not available. Excision should be planned such a way that it will include in eventually mastectomy. Chest X-ray to look for pleural effusion. Canal wall, secondary in lung, mediastinal lymph node, secondary in rib. Chest CT, more reliable method to see lung secondaries. USG abdomen to look liver secondaries, cucumber tumor, ascites. X-ray spine show osteolytic secondaries. Estrogen receptor status, progesterone receptor status are HER2. Neuroreceptor status are 2. Study of discharge, fluid is withdrawn in syringe for cytology. MRI of breast to differentiate carcinoma. Scar from reoccurrence to image breast of woman with implant to evaluate the management of axilla and recurrent disease. It is useful in screening female with high risk. T1 and T2 stage weighted image are taken. Irregular mass with speculation, change in skin and nipple, lymphedema are the finding in carcinoma breast. MRI is not accurate if done within 9 months of radiotherapy in C breast. Both pre-contrast and post-contrast MRI are done. Age biopsy done only when there is a ulceration and fungation. Diathermy should be avoided in incisional biopsy as it may distort the histology of tumor and study of hormone receptor status. Not be possible. Tumor markers CA15, CA33, MRI spine or pelvis show osteolytic secondaries in bone like vertebra and pelvic bone. Radioisotope bone can be to look secondaries in bone in advanced case. It is not done routinely in early carcinoma breast. Indication for women who bone scan is carcinoma breast. T3, T4 advanced disease, advanced node disease, bone pain, bone swelling, pathological fracture, chest, liver secondaries. Sentinel lymph node biopsy, it is very important. Secondary sentinel lymph node are first axillary node drainage the breast by direct drainage. It is designed as sentinel lymph node. Sentinel lymph node biopsy is done in early breast cancer, T1 and T2 without clinically palpable axillary lymph node. It is not done in clinically palpable lymph node. If lymph node is palpable, it's not required. It also done in a multifocal multicentric sentinel lymph node is localized by pre-operative within 12 hours or pre-operative injection of patent blue or 99 technetium radioisotope labeled colloid albumin near the tumor over subdermal plexus around the nipple. Marker will pass through the sentinel node, which can be detached visually as the seen visually as the blue staining or with handheld gamma camera and is biopsies with small incision directly over it. Frozen section biopsy or touch impairment cytology done for presence of cancer cells. If there is no involvement of sentinel lymph node by tumor, the further axillary lymph node dissection is not required. CT chest and abdomen axillary sampling. It is often done with axillary incision. 15 to 20 nodes are removed for the sampling. Next investigations is the blood count, LFT. Newer investigations modalities, core biopsy using computerized mammography, vacuum assisted biopsy using 11 gas biopsy probe, needle localized biopsy under mammographic guidance, histotactic biopsy, 122 5 seats localization biopsy. Treatment, that is usually surgery, radiotherapy, hormonal therapy, chemotherapy. Two basic principles of treatment to reduce the chances of local recurrence and decrease risk of metastasis. So we plan that there should not be recurrence and we want to cure the person. Treatment of carcinoma breast is usually involve the surgery with or without radiotherapy. Systemic therapy is added if there is adverse prognosis factor such as a lymph node involvement, indicating a high ulcer wound of metastatic relapse at the other end of the spectrum. Locally advanced or metastatic disease is usually treated systemic therapy to palliate symptoms with surgery play a smaller role. Algorithm for management of operable breast cancer achieve locally controlled appropriate surgery by local excision and radiotherapy or mastectomy plus radiotherapy, often reconstruction immediate or delayed, combined with auxiliary procedure, await pathology and receptor measurement, use risk assessment tools, stage it by appropriate, treat risk of systemic disease, often chemotherapy, prognostic factor poor, include Rocaptine if HER2 positive, that radiotherapy is a decide above. Hormonal therapy of estrogen or progesterone receptor positive. Now come on the surgical treatment of breast primary tumor. ये चल ही नहीं रही, मैंने अभी चालू किया ना, बढ़ नहीं रहा, आगे स्लाइड आगे नहीं बढ़ रही, स्लाइड शो तो नहीं डाला है। ठीक है, जल्दी जाओ।
एक मिनट में बैक पे आ जाऊँ, एक मिनट से।
Now come on the surgical treatment of breast primary tumor. There are various operations are available. First, early breast cancer. Radical treatment is undertaken with an intention to cure after local excision, along recurrence may occur with remaining breast tissue. It is therefore generally accepted that the majority of patients should be advised to have more radical treatment, either radiotherapy to affected breast after conservative surgery or mastectomy. Most patients prefer to avoid mastectomy, and the most instances, the two treatment options are compatible in terms of both local control and long-term survival. However, the mastectomy is known to be offer superior local control when there is extensive carcinoma in situ or multifocal invasion. The mastectomy may also be better option in some some medial or centrally placed tumor when local excision is expected to be give disappointing cosmetic result. Mastectomy may also be indicated if radiotherapy is contraindicated or unavailable. Locally advanced breast disease, in this primary surgery is contraindicated if there is evidence of extensive skin involvement by tumor of or features of advanced disease such as inflammation or purity orange. Similarly, when tumor fits to axillary lymph node, primary surgery is best avoided. In these circumstances, primary systemic therapy with chemotherapy or endocrine manipulation or both can bring advanced local regional disease and control. This approach is also clearly indicated when distance disease is found to be presentation. Local regional radiotherapy can also be achieved local regional control. Since survival under these circumstances is likely to be poor, it can be avoided and reserved for those cases where chemotherapy, endocrine therapy, manipulation, and radiotherapy have to be achieved local palliation. These operations follow the standard pattern of wide excision of highly symptomatic malignant infiltration followed by reconstruction into healthy surrounding tissue. The indication for such operation are fortunately rare. Now come on the phyloid tumor. This tumor is usually initially excised as a suspected fibroadenoma. Phyloid tumor requires adequate wide local excision, local recurrence, and rarely blood-borne dissemination may be occur. Lymph node metastasis is not a feature of phyloid. Wide local excision or rare occasional mastectomy without sampling or clearing with the standard treatment. Wide local excision, this is indicated for prone malignancy or a lesion that is suspected to be malignant after full assessment. The lesion is removed with a wide margin of microscopically normal breast tissue. If subsequent mastectomy is likely, the scar should be within the ellipse of skin, which would be excised at mastectomy. In inversion of carcinoma in situ beyond the primary tumor may extend to margin of excision and the necessitate a later more radical local excision or mastectomy. If the lesion is impalpable, some method of marking the area to be excised must be undertaken. Similar stereotactic and ultrasound method can be used for core and fine wire markers introduced into the Reason, this can be done imaging shoot under local anesthesia prior to the surgery. Movement of breast as skin appendage, which is the fundamental to control of to concept of mastectomy. The whole breast is excised with an overlying ellipse of skin, which include the nipple and areola. It is done under general anesthesia. Patient placed in a supine position with arm abducted and support on the arm board. In order to prevent shoulder capsular strain and nerve damage, abduction should be less than 90 degrees and the elbow should not be at lower level than the shoulder. The skin ellipse is marked as a horizontal ellipse like natural crease, but some are publicly afford better access of to axilla and medial end of scar will be lower and below the area of the visible cleavage. The width of ellipse is decided by tissue of skin closure. This way. And breast cancer can spread early in the So the lower axillary nodes and lateral border of pectoral measure, the operation follow the same principle of dissection as the level 3 operation as described below, but dissection is only taken to level of lower border of pectoralis minor. Central and axillary lymph node biopsy, we already discussed about that. First node to lymph node of the breast to axilla, then to axilla. This node is identified after injection of either radiopaque or blue dye into the breast and removed from the pathological evaluation. If negative for metastasis, no further axillary surgery is undertaken. That is, axillary clearance surgery is reserved for those with metastatic disease, proved metastatic disease. Surgical treatment or clearance of axilla level 3 clearance, remove of all three group of axillary node. Radiotherapy is an alternative. Surgeon may option for surgical clearance in those patients with high detected risk of nodal involvement, but perform nodal sampling in those with low risk. If metastases are detected in sample node, radiotherapy can be given to axilla or axillary clearance undertaken. Level 2 and level 3 axillary clearance. Level 2 and level 3 clearance may be performed in conjugation with simple mastectomy or wide local excision or lump in part of the breast. It may also be undertaken as an isolated procedure when early axillary node sampling has shown tumor and surgery is felt to preferable to radiotherapy. It may very occasionally be indicated for obvious recurrent axillary disease in patient who has already had radiotherapy, but should be avoided if all possible due to almost inevitable subsequent lymphedema. Surgery after previous axillary surgery or radiotherapy is often more difficult, but operation is essential. Procedure, we have already discussed about axillary lymph node dissection. Once again, patient is placed in a supine position with the adducted similar position as for simple mastectomy with elbow above. The axilla is most often explored through transverse lower axillary incision. It may be lateral end of mastectomy incision or extension of incision of wide local excision. The axilla can also be explored through the vertical oblique incision at the lateral edge of the breast if this incision has already been used for breast surgery. When axilla dissection is undertaken as a part of mastectomy, the breast and axilla content are excised as a single specimen. The mastectomy dissection can be completed except for axillary tail before entering the axilla. The lateral border of pectoralis major is cleared of loose areolar tissue and all loose cellular tissue and level 1 lymph node in axilla are clear following care not to injury axillary vessels and nerve. The pectoralis minor muscle is dissected. It is divided from its into required process. The level second and third lymph node are then dissected off from axilla. The lateral dissection is carried up to the anterior border of lacrymal diaphyse. The clearance of lymphatic node and loose areolar tissue is kept continuous to anterior and inferior aspect of axillary vein, and no attempt made to clear the structure above the vein. The structure so separated, dissected away from the chest wall by dissecting using swab. The nerve serratus anterior is identified along with the lateral chest wall and are preserved. Nerve to latissimus dorsi is identified running along the subcapsular vessels and preserved. The intercostal nerve is dissected and preserved. Hemostasis is secured. Closer suction drain is inserted. One tube is kept in another tube underneath the breast flap. The skin is closed within nylon or silk. MRM Pettis technique we have already done mainly this MRM Pettis simple mastectomy plus level 3 axillary lymph node dissection. It is done under general anesthesia. Supine with arm on operated side supported on arm table. Cleaning pending draping is done. The transverse skin incision is made encircling the nipple and areola encompassing 5 centimeters of skin margin around the mass. Skin flap is raised by sharp dissection, scalpel or scissor or with cautery plane between subcutaneous fat and mastectomy flap. The upper skin flap is raised up to the clavicle and lower flap is raised up to upper quadrant of rectus sheath. Hemostasis done with cautery, raising the breast. The uppermost part of the breast is dissected off from the fascia covering the pectoralis major. A cleavage is created between breast tissue and fascia covering pectoralis major, and whole breast is lifted off from the pectoralis major fascia. Hemostasis is done. The breast tissue is lifted above from the level of clavicle, below up to the upper quadrant or rectus sheath, medially up to midline, and laterally up to latissimus diet side. The breast is allowed to hang laterally, keeping the axillary tail in a continuity with the axillary lymph node. Axillary dissection as described above should be done. Thank you. Thank you so much.
Awesome.